Hello, everyone, and welcome. We are live here at the Health IT Summit in Rockville. I'm Sylvia Oakland, staff writer with GovCIO Media and Research, and I'm joined here by Mitchell Thornbrugh from Indian Health Services. Thank you so much for joining us today.
Thank you.
Yeah.
It's a pleasure to be here.
Congratulations on your Flywheel Award. We're super honored to have you here, and we're super honored to listen to your lightning round talk today.
Awesome.
I think the first thing is just, last time we spoke, we talked about PATH EHR and just kind of what that means. And I'd love to hear any updates that you have and what you're looking forward to. You know, fiscal year end is coming up, but also the end of the year is coming up.
Yeah, great. And I'm trying to remember exactly what we talked about, but certainly we're preparing for a June, July go live next year of our pilot site in Lawton, Oklahoma. So that's a hospital and 2 clinics. And we're working closely with that team on how we build out the PATH EHR. And that's a good segue, because while we have one pilot and it's one site out of our hundreds of sites and dozens of hospitals, we have an enterprise approach even in the preparation. So we put together our enterprise collaboration group, and that group is meant to be kind of a broad national, if you will, or enterprise EHR committee. So the things that, if you're a local hospital, that you would need to, work through with your EHR and your technology, and that, changes how you use it, all those things. We were able to set that up with 200 staff from across the country. So that's federal, tribal, and urban. So not even all federal, but anybody that will be a future user of PATH EHR. And what that does is, even though we have that pilot at that one site, our ECG now represents the entire enterprise. And all of those individuals from across the country are seeing firsthand how we are working through PATH EHR, the good, the bad, and the ugly. I think that's really important to say, because, our team wants to do a great job. I think we're doing an amazing job, but we have to put our ego second. We don't have all the answers. And through those partnerships with that staff that use this software, it's super insightful as we work through like what we thought the answer would be and what ultimately the answer becomes, with that deep, discussion and involvement with people that use the system every day. So these are providers and people that work at our hospitals and clinics across the country. It's so valuable to have that level of engagement, to have that support, because they have to show up to meetings. They have to, in some cases, travel. We're bringing them to Kansas City as we do design workshops. Because while we're localizing it for the Lawton go live and pilot, we're also having to do that enterprise build that everybody will use. So those are probably the biggest updates. We're starting to do organizational change management training at our local sites. So really taking seriously that this is not just an IT project. And so that changes the way we behave and how we communicate with those leaders. But it also means we have to prepare those leaders. We have to, one, tell them what our strategies are, and then give them useful tools that they can use in their interactions with staff, their interactions with elected tribal officials, their interaction with, patients even that have questions about PATH EHR. And so in end of July, we even had our team go out and just stand in the hallway of Lawton. And anybody that wanted to stop and ask questions, patients, any of the staff, because some people are very involved in those meetings, but
right.
In any large organization, there's somebody involved that goes, hey, I haven't been in a meeting yet, haven't heard this. And so we're just really trying to maximize that engagement. So I think that's the high level stuff.
That's all great. And I think, you touched on a lot of things. Partnerships, change management is a big one. We've been talking all day at this conference about how it cannot just be the policy and the technology that is changing. It is that trifecta of people, process or policy, and technology. And I think something you touched on during your lightning rounds that really struck a chord with me was expanding that rural healthcare access. I'm from a town of about 100 people.
There you go.
And, my mom is a nurse herself, and just hearing about some of the issues that she faces in a small town hospital, I can't imagine what that is like in some more remote areas than where I'm at. Do you mind talking about what that expanding access has looked like up until now, and kind of where you see yourself going to achieve the goal that you've set for next summer?
Yeah. Having the technology in place to efficiently see patients, to be able to have insight into what that access looks like, to be able to react to challenges to access to patient care, because you can see a lot of that in the numbers. And obviously there's that local, human factor that has to do with quality of care. And so I'm not advocating for a one size fits all, but certainly you can see trends, and the better perspective you have on the data, you can react more quickly, and more thoughtfully, in a way that it moves that metric. So we often hear about challenges in the field with high vacancy rates. And so as we look at an enterprise approach, and we look at consolidating data, we can start to see the impact of those vacancies and how quickly we fill them, and whether we deploy staff to help shore up that, because that's the other option is we're a federal agency, and we can bring the full force of the federal government to bear on a problem when we need to, and that's a really powerful thing that we overlook. But you have to be confident. And you got to know that what you're doing is making a change. And so we're deploying public health service officers to various locations as needed. We're running a lot of plans with our chief medical officer, looking at critical vacancies, really looking at the planning and, okay, how do we best utilize these resources when we have these gaps? And so I think that's really critical. And then when you look at the same tools right now, when we deploy people, even if they go from our existing system and then the same system at another site, it's very different. Totally different templates. All the orders are called different things. They usually have to be retrained, reoriented.
Wow.
And in a future state, we will be able to, one, have an enterprise approach to that orientation. But that's also, responding to those needs in those rural communities. And then really want to emphasize our use of partnerships. And so not only do we out of the gate partner with a lot of tribes, as we look at their decisions under Public Law 93-638, so tribal self-governance, sovereignty, as they exercise that. Many of them run their own health systems very successfully. And they're able to create health systems that meet their local needs. And there's no better person or entity to really oversee that than the local tribes. And so we have a lot of proof of that in our data as well. And then that partnership, but also even our federal sites, we partner with local communities to make sure that when our patients need services, that we're building that capacity in those communities through partnerships. And so, like you said, a rural community that you came from with 100 people, very hard to even have a primary care provider. And, if you're not careful, and you break into those little silos, you never get enough to kind of have what you need to have a healthy community. And so we really focus on that. And I'm proud of Indian Health Service because we allow our federal service units and then through our tribal and urban programs for them to really fit those limited resources to their specific needs. So maximizing the use of resources in those environments, because every community is going to be very different, and some may need more behavioral health support, others may need primary care, and it all has to do with their demographics, their health outcomes, their priorities, and we're there to support them to meet those priorities along with the IHS mission to improve health outcomes for all of our patients.
Yeah, I mean, you mentioned demographics. It just makes me even think of like the geographic needs that are going to be different. Again, I'm not from the DMV, but let me tell you, the climate is still very different than from back home. So I can imagine there are those nuances as well. And something that you also talked about in your talk was data liberation. And again, that also really struck a chord with me. And I was wondering if you could just kind of dive into that definition a little bit more and how that data liberation relates to the work you're doing with PATH EHR.
Yeah, so PATH EHR gives us an opportunity to really bring our data into a place where we can leverage it most effectively. As I mentioned during the talk, our data is actually in hundreds of separate systems. And you have all those challenges, like we move data to our National Patient Data Warehouse, but you're having to extract the data. And because they're separate systems, there are nuances to the data. And so you have to clean it up. You have to work through errors. Something may happen and a site may stop sending data and you got to go troubleshoot what's wrong with their interface. And so you have all those, like that extra friction, and then you're bringing a limited data set together. But by going to an enterprise EHR, at every level, that data is available. And then we can extract it and use it in ways that we haven't been able to previously without a lot of pre-planning effort and testing. And then you go pull that one data element and it takes months and in some cases years, unfortunately, to get that right, because then as you pull that data from all those separate sources, you start to really understand, okay, they do it a little different over there and a little different over here, and that field does not mean the same thing. So we run into all those challenges, but it's really positioning that data. It's extracting a rich history for Native Americans, in some cases spanning 30 years or more, about their treatment and outcomes. And what I'm most excited about, and I didn't touch on it very much, is we really don't understand how future communities will use the data that we're generating today. And so by positioning that data, we're unlocking that future potential, not just the historical, even though it's historical data, it's really unlocking future analytics, machine learning, all the things that we can start to apply to those rich data sets that can directly help us improve outcomes for Native Americans through that rich data. And so it's about getting it positioned. And right now it's not positioned for us to use very well. In the future state, it is positioned for us to use well. And I also say that in the future state with PATH, data is at the heart of that. And PATH actually sits on the outside of the data model. So we're hoping that, an EHR implementation is going to last maybe a decade. And you're going through major overhauls to update that software. And then our partners are also using their own EHRs. So everybody doesn't have to come use PATH EHR. If they're using an ONC certified product, then they're going to have access to our data, and our data architecture really centers around the 4 Directions hub. And that will hold all of our historical data from our legacy systems. And it is the historical repository that we will feed back into for that data. And so we're hoping that data infrastructure persists for decades, through multiple generations. And so that the data becomes that valuable commodity, not the system we use for the workflows. That's going to change and evolve, but the data is the value. And that's why we say data is at the center of our model. And we hope that it provides, value, extreme value through multiple generations, thinking about I have grandkids now, but what are my great grandkids? I want to solve these problems so their health outcomes are improved and they don't have to come do this.
Yeah, that's what I feel both in government and in culture is something that we really try to do, is how do we make this better for the next generation of users? Again, whether that is yours, mine, whoever that may be. The last thing that I just want to touch on really builds on data, and that is how you're looking at scaling AI and AI's role in this modernization process.
Yeah, so great example. And I touch on that, AI came about as that perfect use case that helped us really understand why we made the decision to go to the commercial software versus the government produced software. And AI is just, the timing is just that talking point. Rapidly evolving, very innovative, high potential, all the things that you want to tap into. And if we were solely relying on government software, we would be doing 100% of that R&D, 100% of that development. We'd be very slow to uptake that. But in our current model, PATH EHR, it's a commercial solution that's being developed for, millions and millions of patients across the country, not just the IHS users. And we're participating in that model and benefiting from all of that R&D that we would have otherwise had to do ourselves. So it's going to rapidly increase our ability to bring that new technology in. And it's something that's vital. This is just my opinion, but I think AI is going to extend all of our professionals. So I've been in technology for a long time. There are things that can be automated. And this is one of those opportunities where, yes, it's automation, but it's more through extension. It's taking your professionals, whether it's nursing, lab, physicians, and you're extending them. You're taking away their mundane work, allowing them to focus on the high value interactions with patients and the decision making, and really leveraging AI in a way that one, increases access to care, because if you can't get in to see a doctor, you have no access to care.
Exactly.
And also, visibility, and standardization. Again, not necessarily to automate or override the physicians, but to really support them in the delivery of gold standard care, which every physician I talk to absolutely wants to deliver the best possible care. And this is a tool that can help them do that. And again, in a way that, when you try to put rules and orders, they usually become stumbling blocks for the providers. And I'm hoping AI actually enables kind of the vision of that, where we're all getting the best standard of care and physicians are being supported through that thing, but they're also able to then ultimately use their decision making to make the right decisions, because that's what we want. Yeah,
really figuring out how to make this a tool that is a tool, for everyday use that's going to make things easier, and not just to say, we have this tool in our toolbox.
Yeah. And you don't necessarily want it to, again, I just don't think the future, until you get into discrete medicine and some more technical things, that it's going to just automate everything. But it's there to support the physicians. I don't know any physician that likes to type their notes. They all want to, they do a great job of communicating. If you've worked with physicians, they're absolutely fabulous writers. And you know why? If you see their notes, they just constantly have to produce and write down their thoughts and decisions. And, I want to position technology to help them automate that, where they're the author, but they're not necessarily having to type every word. I think that promise is something that's been out there, that AI may be able to deliver on and help us really improve throughput, accuracy, documentation, without the burden being 100% on the doctor to do more, or 100% on the nurse to do more. Because we just know that model doesn't scale very well. And usually when we try to implement those things, what we see, and this is why I said data is so important, sometimes you predict it's going to help, but you actually see a decrease in patient access because, you lose one visit a day. Doesn't sound like much, but multiply it by thousands of doctors, by thousands of days, and suddenly your community's not getting all the care that they need. And a really important point for us, and through our partnerships with tribes, we kind of understand this. We partner with tribes to help build facilities through our joint venture projects, very successful. And IHS and the federal government comes in and staffs those. But what I found in my experience is we didn't have the capacity to test the upper limits of our demand. So getting to the heart of this access issue and why automation and tools are so important, we need to do more with what we have. Because when we can build, large clinics and that capacity is immediately filled the next day, then what is there's unmet need. And unmet need translates into poorer outcomes in our communities.
This has been such a great conversation. I'm so glad you were able to join us both for the panels and for this discussion today. So, Mitchell, thank you so much. We appreciate having you on the show.
Thank you. It was a pleasure.